Assalamualaikum. My name is Dr. Umair Akram. The topic of our discussion is invasive management of overactive bladder. Today, we will learn about the following topics: Botox, neuromodulation, DETRUSOR myomectomy, augmentation cystoplasty. Botulinum toxin is a neurotoxin produced by Clostridium botulinum. It is a FDA-approved treatment. It was approved for refractory neurogenic DETRUSOR overactivity in 2011 and for refractory idiopathic DETRUSOR overactivity in 2013. Out of the seven subtypes, subtype A has the longest duration of action, making it the most relevant clinically and most commonly used drug. Here is a diagrammatic representation of action. Uh, um, Botox block the release of acetylcholine. It attached with the synaptic vesicle 2 in synaptic vesicle, and it degrades snare protein. Snare protein is required for the fusion of vesicle with cytoplasmic membrane, which helps it into the release of acetylcholine. That's why release of acetylcholine blocked. And as you all know, acetylcholine is required for nerve conduction and for depolarization. Here are a few clinical uses of Botox. It is used in neurogenic overactive bladder, pelvic floor spasticity, bladder pain syndrome. It reduces the appearance of facial wrinkles, neck spasms, and it is also used to treat excessive sweating at armpits. Right. This is representation of site of injection. We inject Botox through cystoscope, usually through flexible cystoscope in male patients. And uh, as you can see, there are various point where we can give Botox. And the principle is it should be about 1 centimeter from one side to another. And while some surgeons prefer to give Botox in trigone, while some surgeons avoid to give Botox in trigone. It's a debatable thing. Here is a short video in which demonstration of injecting Botox.
Botox therapy for overactive bladder. Approved by U.S. FDA in cases of neurogenic bladder. Cystoscopy. Technique of mixing Botox is very important. 100 unit is diluted in 6 milliliters normal saline. Mixing is done by slowly injecting the saline as the sulfur bonds in botulinum toxin are very fragile. The stock solution of 6 milliliters is now aspirated in 3 syringes 2 milliliters each. Each 2 milliliters is further diluted to make 6 milliliters solution in each syringe. Approximately distance in injections is 1 centimeter. Now injecting Botox.
As you all can see in the video, the Botox is injected through cystoscope. This is a syringe which is present in front of a cystoscope, and injecting it about the distance of 1 centimeter, and the depth is also about 1 centimeter.
Okay, this the phenomena of this Botox injection and actually is called denervation. The Botox is how does it produce? Anybody? What is it exactly? It is a toxin produced by bacteria named Clostridium botulinum. So what does it do? There is a neuromuscular junction, presynaptic terminal there. It prevents the release of acetylcholine. So what would it do? Yes, Shirjan?
As the botulinum toxin is injected, it there's endocytosis at the presynaptic nerve terminal, and then there's a series of changes, but it releases its light chains and heavy chain. And what exactly light chain and long chain does, I don't know, but then it inhibits the release of acetylcholine the postsynaptic junction, and then it in that way it blocks the nerve conduction.
What does acetylcholine does actually?
Acetylcholine, in case of bladder in detrusor muscle, it causes contraction.
It causes a depolarization, and
Depolarization.
causes the muscle twitch.
Yes.
So it inhibits it all, but this toxin. So in other words, it paralyzes the mechanism. So what does it do? Those involuntary contractions that a patient is bothered with, that may cause him what we call a detrusor overactivity, and that may, if the pressures are raised, and then can leak, go into the incontinence, raising the bothersome of the patient. So it inhibits all the phenomena. So okay, with the site introduction site, the controversy is there. A number of site to be injected, like 10 to 30, dosage 0.5 to 1, is the dosage 5 to 10 international units per kg, 100 to 300 international units. What EUA guidelines suggest is that about 100 international units for the idiopathic refractory detrusor activities. There should be 100 units used, and for the detrusor overactivity refractory to the other medical regimes, 300 international units to be injected. Site distribution should be equal, 1 cent each, and the other discussion is that either it should be intra muscular injecting depth to the detrusor muscle, or it should be the submucosal. And another thing is, another point is trigon to be spared or to be injected. What would happen if trigon is injected? See, there's trigon area is not mentioned for the injection site here. What would happen? Anybody? So actually, EUA suggests it should be supratrigonal, and theoretically, what the literature suggests, it doesn't impact as much, but it can cause a VUR. Okay, and but those who favor it, or those who have practiced injecting trigonal area, they suggest, because of the abundant sensory innervation at the trigon area, it is advantageous.
Here are the few advantages of Botox. It's a daycare procedure, minimal invasive, symptomatic improvements such as urgency, nocturia, frequency, and urinary incontinence. And it significantly improves quality of life. Here is a few data spotting the use of Botox. Randomized clinical trials have documented the clinical effects of onabendolum toxin A for neurogenic detrusor overactivity and idiopathic detrusor overactivity, wherein drug decreases the incontinence episodes, frequency, urgency, and improves patient quality of life. This is published in these papers. And the other data, the drug was also shown to be effective in patients with overactive bladder.
So the aim and the understanding at least should be this way. What we are talking about is improving the quality of life and minimizing the symptoms, especially this urgency, plus manager, urgent incontinence, frequency, and nocturia. And okay.
Here are a few disadvantages. It's expensive, and patient have to come for repeat session after every 6 to 8 months. Here are a few adverse effects of Botox. It may cause bladder pain, UTIs, transient hematuria, urinary retention, and temporary inability to empty bladder, which may require CIC. But
Okay. In Western world and in this Botox, this treatment modality has revolutionized the whole management of overactive bladder, and it has obviated the need of going for more invasive procedures like augmentation cystoplasty. And the only concern with this treatment is requiring the need for repeating again after 6 to 10 months of duration. And still, those who have a refractory response or who do not respond on the Botox, they may need an invasive procedure like augmentation cystoplasty.
but it results in symptomatic improvement in more than 80% of patients. Our next topic of discussion is neuromodulation. Percutaneous tibial nerve stimulation and second of neuromodulation. First of all, we will discuss about percutaneous tibial. It's a phenomenon first described in 1987. Posterior tibial nerve, as we all know, is a peripheral nerve with root value of L4, L5, S1, S2, and S3. It has both sensory and motor components. Sensory component supply cutaneous innervation to sole and heel. That's why during treatment, patient may not tingling sensation along the distribution. While its motor supply, it give motor supply to great toe, which helps in flexion of great toe.
Okay, they may sound new terms, as in we do not practice here, but still what we are supposed to learn today is we are supposed to learn this sensory and motor at least response or supply and how does it work. Okay, the thing that this slide is mentioning here, this tingling sensation of the sole and heel. What does it mean actually? While stimulating or giving this, they are first tried, like they go through a trial. They are given these stimulations first and to see the common root innervation of the bladder, outlet, and the pelvic floor. So to know if it is going to respond and then to proceed for such procedures.
Exact mechanism of is unknown, but the proposed theory is that eclectic stimulation of posterior tibial nerve modulates innervation of the bladder and pelvic floor muscles. It is given by using 34 gauge needle placed superior to medial malleolus, and we will try to get closer to proximity to posterior tibial nerve, and it will connect it to external battery stimulator. The 30-minute session weekly for 12 weeks. And maintenance therapy depends on the institution policy, but typically once a month. Here are the few contraindications for using PTN. Pregnancy and implantable pacemaker are absolute contraindication, while peripheral neuropathy and peripheral edema is a relative contraindication. Sacral neuromodulation. It's a type of neuromodulation, and its mechanism is also unknown. Here are few theories. It activates somatic afferent axons that modulate sensory processing and micturition reflex pathway in the spinal cord. DETRUSOR overactivity can be suppressed by direct inhibition of bladder preganglionic neurons. Inhibition of interneural transmission in afferent limb of micturition reflex can also block DETRUSOR overactivity.
So if we just can stop here and refresh our own memory about the interplay of the sensory root as well as the motor root from our previous knowledge of neuroanatomy. Noman, can you explain from where this sensory root comes into the spinal cord, and what's so special about it? Is it the anterior horn or the posterior horn?
So it exactly from the memory it comes from the posterior horn.
Posterior horn. So before it goes into the posterior horn, there is another thing, another small sort of globular structure. What is it?
And
It's known as posterior root ganglion. So that posterior root ganglion is very important because it has got a direct communication from the higher centers. Higher centers are pons, cerebellum, and cerebral cortex, internal capsule. So these are very major centers of nerve control down the line, muscles as well as other structures. So from the posterior root ganglion, there is something which is like a spinothalamic tract, right?
yes,
So it has got its own modulatory effect. The second thing is when it enters into the stimulus enters into the spinal cord, before it goes to the anterior horn cells, which is the motor root, there is another group of neurons which are in the lateral horns. And they are also very important. Why they are very important? Since we are all urologists, we are more concerned with evacuation and storage of the bladder, the whole circuit. So this circuit is actually governed and controlled by lateral horn cells. So the lateral horn cells, if they are intact, they are working, they can have a direct contact from pontine nuclei. The earlier lecture in the previous week, some of you who were there in the previous week can understand that there were two pontine nuclei, the median and the lateral pontine nuclei. So they directly control the interneurons, the lateral horn cells. They are not connected with the motor neurons. They are not connected directly to the posterior root ganglion. Why this is more important in understanding as a modern day urologist, all of you are sitting in this hall, is if you are into the game of sacral neuromodulation, if you are into the game of controlling the bladder somehow, maybe today, maybe in future, you got to play with smaller instruments which are like electrodes placed in the spinal cord. Somebody who has got quadriplegic, somebody who has got a Brown-Sequard syndrome, where the spinal cord is transected. Now, all these patients who are traumatized patients, they come to you for help because they have got an automatic bladder. Their bladder will be working just like a small child's bladder. A 1-year child has got a circuit, a neural circuit, which is without any control because all the reflexes are not actually being in place. So but there are many things which all of us have to understand from our own neuroanatomical knowledge, because this is the modern day urology. If you go to, for instance, in Europe, this is the kind of urology that they play, and this is very important. There is a center in Bristol in UK that is actually a specialized center for all these spinal cord injury patients who have got problem with defecation, who have got problem with urination. And what they do is they all interplay with sacral neuromodulation and neuromodulation as such.
Targeting neural communication to restore function. Medtronic sacral neuromodulation for the treatment of overactive bladder, mechanism of action. Overactive bladder, or OAB, is a urologic condition defined by urinary urgency with or without incontinence, urinary frequency, and/or nocturia. OAB affects about 37.4 million adults in the United States. Neural pathways in the brain, spinal cord, and peripheral nerves together regulate urine storage and elimination through coordination of the bladder, urethra, and pelvic floor muscles. During bladder filling, sensory or afferent signals convey information on bladder fullness, in part via the sacral nerves. The signal travels up the spinal cord to the brain. In response to the full sensation and at a socially appropriate moment, the descending, motor or efferent brain pathways, which are under voluntary control, are activated by conscious thought. This causes the urethra and pelvic floor to relax and the bladder detrusor to contract, resulting in voluntary urine release. Dysfunction of the sensory and motor pathways alters the checks and balances that are critical to voluntary bladder control. In OAB patients, brain activity has shown abnormal responses in areas of the brain believed to be important in recognizing urge and frequency, and decreased activity in areas believed to be crucial to voluntary bladder control. Normal bladder functioning can be restored by influencing the sacral nerves, which convey a portion of the signals between the bladder, pelvic floor, and the brain. Medtronic sacral neuromodulation delivers electrical stimulation to a sacral nerve via an implanted neurostimulator. The neurostimulator provides an electrical charge to an area near the sacral nerve, resulting in altered neural activity. This stimulation likely depolarizes the nerve, causing an action potential that propagates impulses along the axon as if the neuron naturally fired an action potential. As a result, it is thought that abnormal sensory input from the bladder is modulated. OAB patients with sacral neuromodulation exhibit patterns of brain activation similar to that of patients with normal function when compared with OAB patients without sacral neuromodulation. These effects are observed in areas of the brain involving sensation, awareness, urge, and timing of urination. This suggests that sacral neuromodulation patients experience normalized sensory signaling to the control centers of the brain, while motor pathways are uninhibited so as not to suppress voluntary voiding. Unlike other therapies that target the bladder, bladder regulation via sacral neuromodulation occurs without physically influencing the bladder or sphincter muscles. Medtronic sacral neuromodulation with the InterStim system is a safe and minimally invasive treatment option for refractory OAB patients that provides continuous control through effective long-term therapy delivery.
So what does this video actually shows? What does this phenomena affect on? Sensory or motor? Afferent impulse or efferent impulse?
Here's a few indications of sacral neuromodulation: non-obstructive urinary tension, overactive bladder, and it is also beneficial in the patient of chronic fecal incontinence. Here is a small video of implant, how it implanted into the patient. First of all, we will test, and if there is a contraction of muscle on test, then we will implant.
This animation presents the InterStim full implant procedure. The full implant procedure involves implantation of a tined lead and neurostimulator following a successful PNE trial procedure. Position the patient on the table and administer sedation. Prep for sterile surgery by swabbing the lower back, sacral region, and buttocks with an antiseptic. Drape the patient to allow for observation of the pelvic floor and great toe motor responses. Ensure a clear view over the buttock and perineal area. After the proximal end of the white patient
सॉरी, इस वीडियो में जो चीज़ ये दिखाने जा रहे हैं, इसके लिए जो अंडरस्टैंडिंग पॉइंट ऑफ व्यू से जो चीज़ आपको नज़र पे रखनी है वो ये है कि एक तो सेंसरी रिस्पांस ऑब्जर्व किया जाता है और मोटर रिस्पांस ऑब्जर्व किया जाता है। जो हमें पता होगा कि ये जाएगा थ्रू S3 फोरामेन और समवेयर नियर बाय S3, S2, S4। जब हमें पता होगा कि उनका सेंसरी क्या रिस्पांस है, मोटर का रिस्पांस है, तो ये ऑब्जर्व करने से विल कम टू द पॉइंट कि द स्टिमुलेशन इज वर्किंग और नॉट, सो टू फिक्स और प्लेस द प्लांट इन अ प्रॉपर पोजीशन, द इलेक्ट्रोड्स इन द प्रॉपर पोजीशन। S2 पे क्या आना चाहिए? मोटर रिस्पांस। काफ मसल कॉन्ट्रैक्ट होंगी ऑफ द एप्सिलेटरल साइड और एनल विंग आएगा, एनल टोन विंग आएगा। एंड सेंसरी देयर वुड बी सेंसेशन अराउंड द बेस ऑफ द पेनिस और वजाना इन द फीमेल। S3 पे क्या रिस्पांस आएगा मोटर एंड सेंसरी? अनुमान? पेलोज ऑफ पेल्विक फ्लोर और जो बिग टो प्लांटर है फ्लेक्शन होगी, मोटर रिस्पांस होगा ये S3 का। और सेंसेशन जो कहते हैं बाइसाइकिल डिस्ट्रीब्यूशन एरिया, वहाँ की सेंसेशंस आती हैं S3। और S4 में भी बेलो पेल्विक फ्लोर अलोंग विद उसकी सेंसेशन जो आएंगी पेरीरेक्टल एरिया में। तो ये आप, क्योंकि ये स्टिमुलस दिया जा रहा है, उस पे रिस्पांस असेस किया जा रहा है और देन लीड जो है इलेक्ट्रोड्स प्लेस किए जा रहे हैं।
on the table and administer sedation. Prep for sterile surgery by swabbing the lower back, sacral region, and buttocks with an antiseptic. Drape the patient to allow for observation of the pelvic floor and great toe motor responses. Ensure a clear view over the buttock and perineal area. After the proximal end of the white patient cable is handed off the sterile field, attach the ground pad to the patient's heel. Connect the red pin of the long screener cable to the ground pad and the black pin to the white patient cable. Finally, plug the adapter end of the long screener cable into the test stimulator. After verifying the settings, turn the test stimulator on and verify that the status light is blinking. To identify landmarks using AP fluoroscopy, first mark the midline. Using the sacroiliac joints as a guide, locate and mark the sciatic notches. Draw a line connecting the notches. The S3 foramen is located about 2 centimeters lateral to the crosshair formed by the midline and the sciatic notches. The foramen needle skin entry point will be located about 2 centimeters cephalad of the S3 foramen to accommodate a 60-degree angle insertion. Inject a local anesthetic to numb the skin near the entry point of the foramen needle. S3 is the target foramen. The foramen needle skin entry point will be located 2 centimeters cephalad of the S3 foramen. The needle should be placed at approximately a 60-degree angle relative to the skin and should always be oriented in a cephalocaudal direction. The needle tip should be inserted to a depth just below the anterior surface of the bone. To confirm ideal placement, connect the white patient cable to the non-insulated portion of the foramen needle and turn the A dial on. Slowly dial up the amplitude on the test stimulator. Observe for motor and sensory responses. The desired S3 motor response in the pelvic floor is a bellows, a pulling inward or deepening of the intergluteal fold. The desired foot response for S3 is a plantar flexion of the great toe and occasionally other toes. For women, the S3 sensory response is often vaginal sensation extending to the perineum and rectum. In men, the common S3 sensory response is sensation in the rectum extending to the scrotum. To insert the lead introducer, first remove the foramen needle stylet and replace it with the directional guide. Then, gently remove the foramen needle, being careful to stabilize the directional guide so it is not removed. Make a small skin incision at the exit site of the directional guide. Using live fluoroscopy, place the lead introducer sheath and dilator over the directional guide and advance into the foramen. Twist the hub of the dilator to unlock it from the introducer sheath. Remove the directional guide and dilator, leaving the introducer sheath in place. The tined lead has 4 electrodes, numbered 0, 1, 2, and 3. 0 is the deepest, most distal electrode. Insert the tined lead into the introducer sheath and advance the lead to the proper depth. To confirm the ideal lead placement, ensure all 4 electrodes are distal to the introducer sheath and test for response. Once appropriate responses are obtained, the tines can be deployed. To deploy the tines, hold the lead in place and carefully withdraw the introducer sheath. The tines will deploy as the sheath is removed. The lead stylet is removed along with the introducer sheath. Test all 4 electrodes again to confirm previous responses after deployment. Obtain final lateral and AP images. Identify where the neurostimulator will be placed and inject local anesthetic at the skin and surrounding tissue. The pocket site should be located below the iliac crest and lateral to the edge of the sacrum. Make an incision just large enough to accommodate the implanted components. Create a pocket using blunt dissection and electrocautery. It should be no deeper than 1 inch for the 3058 InterStim 2 INS to ensure proper telemetry with the physician programmer. To avoid infection, it is recommended that the neurostimulator implant site be irrigated with antibiotic solution in sterile water. Do not use saline. Using the tunneling tool loaded with the passing straw, tunnel from the lead incision to the pocket incision, taking care to avoid damage to the lead. Make sure the tunneler passes through the fat and is not too superficial. Unscrew the tip and remove the tunneling tool, leaving the straw in place. Carefully pass the lead through the straw until it emerges at the pocket site. Remove the straw at the pocket site. Dry the contact points on the lead and insert the lead into the header of the neurostimulator, making certain the blue tip is inserted as far as possible. Use the torque wrench to tighten the set screw on the header until you hear a click. If the lead cannot be advanced, use the torque wrench to back the set screw out slightly. Do not remove the set screw. After confirming proper fit, insert the neurostimulator into the pocket with the etched side facing outward, away from the muscle. Irrigate with antibiotic solution in sterile water. Do not use saline. With the neurostimulator in the pocket, use the physician programmer to check impedance and verify that all InterStim system components are correctly connected and tightened. Assure hemostasis and close the pocket with subcutaneous and skin closure, taking care to leave no dead spaces. Secure the incision and exit site with dressing. Use the clinician programmer to program the neurostimulator and document the settings. Provide the patient information on post-op care, follow-up guidelines, and instructions on how to use their handheld patient programmer.
Here are the few contraindications. We cannot use neuromodulation in those patients who have urinary outlet obstruction, pelvic infection, or pregnant females. Detrusor myomectomy. The next topic of our discussion is detrusor myomectomy. It is also known as bladder autoaugmentation. It's a simpler, lesser morbid alternative to enterocystoplasty. In this, we excise a portion of detrusor muscle, bladder epithelium, and lamina propria form a large mouth bladder diverticulum, which result into increase in bladder capacity and decreases intravesical pressure. Here is a combined approach. Combination of auto-augmentation and the ability of bowel and stomach to survive with removal of 3 epithelial lining. The initial combined approach, we used stomach, but we also use colon as an alternative. Mucosa of the gastric flap with pedicle is removed and the remaining muscular flap is transferred to auto-augmented bladder. The potential metabolic complication in urinary reconstruction with bowel are due to the presence of gastrointestinal mucosal layer are obviates. Here are the few advantages.
So this is better known as gastrocystoplasty rather than enterocystoplasty. because you are taking half of the bladder, half the stomach down into the area of the pelvis. So this is gastrocystoplasty,
Yes.
and this is written as such in all the operative urology textbooks.
And for demucosalized, I think large gut is better option because we can remember that one pediatric surgeon operated 2 cases in children. They used large gut and they demucosalized the large gut and then they removed the all detrusor muscle so that to avoid absorption and metabolic problems. So, Dr. said right that this is gastrocystoplasty.
Yes, sir.
And demucosalized enterocystoplasty where large gut is used.
Yes, sir.
Because if you see the lining epithelium of the stomach as well as the bladder, there are tight junctions, and the tight junctions are necessary for the acid not to pass through. So both the surfaces are actually exposed to acid, which is HCl, hydrochloric acid. So it's the stomach as well as the bladder. So the most compatible urothelial surface for the bladder is stomach, as common sense tells us.
Sir, actually, it was introduced in 1989, and it began with just incising the detrusor. So to bring the mucosa out as acting it as a diverticulum and increasing the capacity. Later on, different surgeons keep trying it and then found it that the capacity over the time did not improve, and then the symptoms also did not improve over the time. So they found the need, and then the patient had to go for the other conservative conventional augmentation cystoplasty. So when they did it and they found this diverticulum, when they opened it and then found the diverticulum they had taken out, this mucosal, they found it was fibrous and thick like a leather. So due to the collagen infiltration there. So what they felt a need to cover this pouch, and for that purpose they began to use the gut or stomach, flap of stomach along with the pedicle, and removing the mucosal layer, and then putting it over the this pouch, outpouched area of this, and then. But the problem with this, it takes a lot of time. Learning curve is longer. It causes a lot of bleeding, and duration of the surgery is also longer than the other procedures.
And results are not good.
Results were not good with this, just the incision of the detrusor only. There were two. There were surgeons who were incising it. There were surgeons who were excising the part of detrusor and then adding, fixing it with the lateral edges with the psoas muscle, and so on. But the result did not prove to be good with this detrusor incision or excision.
Some people used omentum as well to cover the bladder in myomectomy, and incision they called it myotomy.
Myotomies, yes, sir.
Here are the few advantages. The risk associated with this GI segmented incorporation into urinary tract are obviated, and it can also be performed in patients who have bowel disease such as IBD. And but patient have to use CIC, and there is a risk of bladder perforation. Our next topic of discussion is augmentation cystoplasty. Augmentation cystoplasty is a well-established technique that typically involves adding an enteric segment to the bladder to increase its size. The goal of therapy are urinary accommodation in bladder at low pressure, improve bladder capacity, decrease incontinence related to detrusor overactivity, and preservation of renal function. Here are the few indications. Poor bladder compliance, reduced bladder capacity, detrusor overactivity causing renal impairment, and failed conservative and other invasive treatment options. These are the few contraindications. We cannot use gut in the patients with IBD or IBS and or short gut syndrome, and renal disease is a relative contraindication. For augmentation cystoplasty, we usually use ileum, sigmoid colon, and stomach. The most common type is ILEOCYSTOPLASTY. Because of reconstructive urologist familiarity with ileum and ileum ability to easily reach to the pelvis. Where I would like to demonstrate a little bit. First of all, we will take ileum about 25 to 40 centimeter, about 50 to 20 centimeter away from ileocecal junction. Then,
Why are away from the ileocecal junctions?
Absorption of vitamin B12 and intrinsic fat and other minerals in the distal portion of ileum.
What else? Vitamin B12, okay, then in
bile salts. Bile salts. Bile salts helps in absorption of vitamins, fat soluble vitamins.
fat and fatty acids. And what if we take them? What would be the consequences? As in vitamin B12 deficiency over a long period of time, and then when bile salts.
If there is bile salt malabsorption, so fatty diarrhea, cyturia is while the megaloblastic anemia, vitamin B12 deficiency anemia, if the liver is normal, the reserves within the liver is up to 3 to 4 years. So it develops a longer time as compared to the fatty diarrhea due to bile salt malabsorption.
Okay, and then the segment selected, he said 25 to 40 centimeter. How do we decide it? Okay, so upon depending upon the systematic capacity of the bladder, we then tend to decide how much gut are we going to use.
And second thing, maybe how you want to reconfigure your pouch. If you want to make it W, then you will have to take larger segment. If you want to make it U, then you can use 25-30 centimeters. So again, the reconfiguration of segment as well, both capacity and reconfiguration of segment.
After taking segment of ileum, we will restore the gut, and we will wash segment of ileum which we took and remove all mucus. And after that, we will detubularize the ileum segment, and we will convert into different pouches like U pouch, W pouch, or S pouch, depends on the requirement. Then we will give cystotomy incision. Cystotomy incision can be given either transverse or vertical. It will be from one uretary orifice to other uretary orifice, and anteriorly the pouch will be placed near the neck of bladder, and posteriorly it will be attached where tension-free anastomosis is possible. And after that, we will place SPC in native bladder, and we will make mitrophenol either using appendix if available, or can we also use ileum or other if appendix is not available or diseased.
Well, please conclude.
Yes. We can also use colon. So segment colon can be redundant in chronically constipated neurogenic patient and easy to position on the bladder, and has large lumen and abundant mesenteric blood supply. But it also has some disadvantages. More significant metabolic disturbance, increased mucus production, and anastomosis leak can have disastrous outcome. Gastrocystoplasty.
And another important disadvantage is the more chances of malignancy.
Yes, more risk of malignancy. Yes. Gastrocystoplasty, it decrease mucus production and less bacterial colonization, but there are risk of hematuria, dysuria syndrome, peptic ulcer in bladder, augmentation, perforation, increased gastrin production, and malignancy. Here are the few complications which can occur after augmentation enterocystoplasty, and as in the picture we can see large vesical calculi. It's a common complication which can occur in patients of augmentation cystoplasty. Metabolic complications, mucus production, recurrent UTIs, bowel obstruction, hematuria, dysuria syndrome, small bowel bacteria growth, persistent VUR, obstruction at the site of implantation, reservoir perforation, malignancy, or may revision is required in some patients. Here are the few metabolic complications, and it depends on the segment of GI we took. If stomach, there is if we took stomach, and then there is hypokalemia, metabolic acidosis, and elevated aldosterone. If we use ileum, and then there is a risk of hypocalcemia. While jejunum, the important thing is it may result into elevated renal level and angiotensin. Thank you.